go through chapter 2. Let's start the slide show here. This chapter talks about pharmacodynamics and pharmacokinetics. And think of pharmacodynamics is when you swallow a pill, how do the cells react? How does it take in that medication? And there's various ways it does, but that is what pharmacodynamics is in a nutshell. So in the different mechanisms, when you swallow a drug, is this type of drug made so it replaces a substitute for a missing chemical you may have in your body? Or does it increase certain activities? Does it slow certain activities? Sometimes some antibiotics will do that. Or does it interfere with the functioning of foreign cells? Antibiotics, think of antineoplastic agents. So many drugs attach to receptor sites, and there's different types of mechanisms. So for example, there's agonists that attach right to the receptor site to get into the cell to work. We also have some competitive antagonists, so two drugs that are competing. There's also a non-competitive, which I'll show you on a picture. Sometimes drugs and the enzymes interact with each other, and selective toxicity is where there's a specific if the medication is so specific that it'll only attach to the area that it needs to attach for it to kill what it needs to kill or fix what it needs to fix. All right, so here's a lock and key picture here. So if you look at the top on A, this is an agonist interaction with the receptor site. So you have drug A, an agonist binds to these receptor sites that are on the cell. See the purple arrows? And then we have, so this is the molecule of drug A. And then we have drug B that can't bind to the receptor sites, so it doesn't do anything. So that's an agonist interaction when you're taking two different medications. So a drug A is an agonist, and then drug B is unable to bind to the receptor sites. Now you have a competitive antagonism. This is where drug A, you have your agonist, and it is circling around trying to get to the receptor sites. But drug C, it's an antagonist to the specific drug A, and so it basically is competing, and it grabs the receptor site, so drug A can't. So it alters the way that drug A would work, or perhaps drug C, maybe you can have toxicity. Now we have a non-competitive antagonism where you have drug A again. See, it's trying to get on the sites, but looks like there's some receptor sites here available. But you have drug D, it's a competitive antagonist of drug A that binds to different receptor sites from drug A, but still prevents drug A from binding. So these are on receptor sites, different receptor sites, but still won't let drug A from binding. So those are just some examples of pharmacodynamics, meaning how are the drugs that you take, how are they affecting the cell? How are they binding to the cell? How are they getting into your body? Now pharmacokinetics is the study of, now you took the pill, how is it absorbed, how is it distributed, how is it metabolized, how is it biotransformed, and how much goes out into your system actually. Because remember, when we do that first pass effect, which you swallow a drug, so by the time it gets to your circulation with metabolism, very little of it will go into your bloodstream, which is why a lot of times you need a higher dosage of oral medications than you would if that same medication was given IV. And then also how drugs are excreted. There's also pharmacokinetics consists of what is the onset of the drug action. So when's the onset of the drug? So if you look in a drug book or your resource and look up a drug, it'll tell you what the onset, when does it start working. Then you have your half-life. So how long does it take for half the drug to leave your body? And how long does it take for the drug to leave your body completely? And that's by doing that calculation of taking the half-life that you find in the drug book, and it'll tell you exactly. So if the half-life is 2 hours, 2 hours after that, you times it by 2, then half the drug will be out of your system in 2 hours, and then 2 hours after that, the entire drug will be out of the system. When does it peak? When does the drug work at its best, or it's at the peak in your system? How long does it last? And then how is it metabolized? And where is it excrete? So all of these will be in a drug book under each medication that you look up, because these are important to know. All right, I'm going to skip this one. Basically, let's look at this. I haven't looked into this too much. So we have absorption. Okay, absorption, distribution. Yeah, so we have it's absorbed. You take the medication. So remember, you can take it orally, or is it going IM into the muscle or in the subcutaneous tissue, or is it going directly into the vein, or sometimes they go directly to the site. So we'll do, say, corticosteroid injections right into the site that's inflamed, like knee injections, shoulders. So that is the site and the absorption. Then it's distributed to tissues and wherever it needs to go. And then it's metabolized. So it's metabolized mainly in the liver. Sometimes you have some medications that are biotransformed in the kidneys, but most of the time these chemical reactions with the drug biotransformation occurs in the liver. Also plasma, that can happen. That's what this word is below, what you can't see. And then it's excreted by the kidneys, sometimes the lungs. So think about inhalers. All right, so here's some things that are important to know. So critical concentration. So what is the amount of drug that's needed to cause the therapeutic effect? So what's the dosing? If you look it up again in a drug book, it'll say initial dose 25 milligrams. I'm using this for an example. Let's say I'll use sertraline. Sertraline is an antidepressant that's given for depression, anxiety, among many other things. But if you look it up in the drug book, it'll say initial may start at 25 milligrams and move up to 50 milligrams. And that helps you figure out, well, what is the critical concentration? How much does that patient need that's going to have a therapeutic effect? Loading dose. Some drugs need a loading dose. So an example, I take Emgality. It's actually a monoclonal antibody. It's an injection I give subcutaneously to myself once a month. That is a migraine preventative medication. And you need a loading dose of it. So the first time I had to give myself 2 injections, so 2 120 milligram injections, because you need that loading dose for it to reach its therapeutic effect and maintain that upper curve so it's working. And that way you built up the amount in your body, and so it's called loading dose to start working, and then you can start giving the regular dose after that. There's many drugs that require loading dose. And then the dynamic equilibrium, how much of the drug actually reaches the body. So there's many factors. So it could be the way it's absorbed, how you're taking it, if you're taking it by mouth versus IM. Absorption, a lot of things are going to happen before it really gets into your system to reach its therapeutic effect. How is it distributed? How is it biotransformed or metabolized? And how is it excreted? It also would have to do with your age, the disease states, if you're taking other medications. So all of the dynamic equilibrium in a perfect world, we want this to be as perfect as possible, but many of us take other medications and age is affected by it also. Okay, so what is an action of a drug? Is it A, to increase enzymatic reactions in the body, to alter a missing chemical, to depress or slow cellular activities, or to increase the effect of foreign substances? So the answer is C. So an action of a drug is not to increase any reactions, alter a chemical, or to increase the effect of foreign substances. This is the best answer. Although it does the other things we said in the past slides, it also depresses and slows cellular activities. So it could be a cancer cell, for example. All right, so what happens to a drug? This is absorption. What happens to the drug by the time it's introduced in the body? So you swallow a pill or you're given an injection until it reaches the fluids and tissues. So what is happening? That's absorption, how it's absorbed. It depends how you take it. The oral route is the most common, and remember, it goes through that first pass, it's called. First pass, I always think it's going through multiple roadblocks and barriers and pushing through, and by the time it gets to where it goes, the drug, part of the drug is falling off, or it's missing or broken. That's how I think of first pass. That's going by mouth, and it has to go through the stomach, and many times food will affect how it's absorbed. Usually food will actually increase the enzymes in your stomach, so it will help the drug absorb quicker. There are some drugs though that don't, that actually slow it down, so you take it on an empty stomach. But most drugs need that acidity. That is why many times people that are on the proton pump inhibitors for stomach ulcers, like Prilosec, Prevacid, omeprazole is another word, that's the generic. It shuts down those proton pump inhibitors that prevent your stomach from making acid. And so even if you eat food and you're taking those medications on a regular basis, other prescription medications may not absorb as well because you've been taking those medications. You don't have enough acid to absorb the drug to its full potential. So the absorption process, as I know you're learning in patho too, is passive diffusion, active transport, and filtration. Remember, passive diffusion is from an area of high concentration to low. It's easy to pass through. Active transport needs a carrier. So whether it's a protein carrier to get it through the cell, then it needs that. All right, so these are all the ways that you can take drugs. I think the only one I really didn't mention, there's obviously, there's rectally. People that can't take oral medications sometimes take rectal medications. If they have a fever, we'll give Tylenol rectally. There's also antiemetics for nausea given rectally, and babies get things rectally, as well as, let's say, people on hospice or those who aren't able to eat anymore, we're giving them something that can be given rectally. And think of stool softeners, stuff that goes right to that lower GI tract, so they can you can have a bowel movement. Mucous membranes, if you put it under your tongue, so sublingual or in your cheek, it's absorbed quicker than swallowing the pill whole because it gets into those mucous membranes and gets into the vascular area. So it reduces the time. So think of nitroglycerin, someone with chest pain, you want them to have something that's going to absorb immediately. So you put that under the tongue, and that's going to dilate the blood vessels and hopefully increase blood flow. Topical skin, that gets absorbed. There's like fentanyl patches. There's many different types of compounds and medications you can put on your skin, steroid cream, etc. And then there's inhalation, such as inhalers for asthma, COPD. All right, and now let's go to distribution. So we've absorbed the medication now. So now it needs to distribute throughout the body. So how does it do that? It's the movement of the drug to the body's tissues affected by the lipid solubility and the perfusion of reactive tissue. So is it protein binding? Does it go through the blood-brain barrier? Remember, there's a lot of medications that don't go through the blood-brain barrier, and that's what kind of helps us from not feeling tired, although there are a lot of medications that some of them slightly do. One example is Benadryl. It goes through the blood-brain barrier, and that's why we get fatigued, just like sometimes people just feel out of it with that. But if you take Zyrtec or Claritin or Allegra or Zysol, that's an antihistamine too, but it takes out that blood-brain barrier component to it. so you don't feel that tiredness. Zyrtec does have the potential a little bit to cause fatigue, but it's really made to not go through the blood-brain barrier. And as well as some drugs will get into the placenta and breast milk, which is why we talked about the pregnancy categories to determine if it's safe or not. Some can go through the breast milk and the placenta, and it's okay, as we learn that a class A would be your Tylenol. All right, let's keep going. Metabolism. So the liver is the most important site, and we call biotransformation metabolism. So this is when it changes into less active chemicals. We talked about that first pass effect. So it's broken down. There's enzymes that are released from your liver, and the drug is broken down. So again, orally, by the time it's broken down, it's much less in your body, which is why you need a higher dose. But all drugs are broken down in some form or another. Excretion, how does the rest of the drug get removed from the body? So your body may not necessarily need 100% of that drug, and eventually it metabolizes and it gets filtered out. So most drugs are removed in the kidneys. There's some that are removed in the gut. So one example would be Welchol, which I can never say the generic colecivim. It's Welchol, and it's actually helps decrease triglycerides, cholesterol, and it also can help bring down blood sugars a little bit. But that is absorbed in the gut only. There's Linzess that's out there, Miralax for your gut. Linzess, it's only really working when we say the gut, we say it's really just working in the bowels. Now when we go to half-life, remember it takes, how long is it for the drug to decrease to 1/2 at the peak level? And it's affected by absorption, distribution, metabolism, and excretion. So while we can calculate as much of an accurate half-life as possible, we also have to take into consideration these 4 things, that the half-life can be affected. So if someone has kidney disease, renal disease, liver issues, or even, again, taking those proton pump inhibitors that are decreasing the acid so it can absorb as well. And if you see here on the graph, remember we talked about critical concentration, this is exactly where the drug needs to be. So when you take an oral medication, it peaks here. So we talked about peak, and then it goes down to the critical concentration, and then it ends up leaving the body. So in your half-life, it is around, say, 2 hours, it looks like. But if you give it IV, as you can see, it's going to go directly in your system. It's going to peak here. It's not going to peak later. Remember, it has to go through this absorption through the stomach. But if you take the IV, it's going to peak pretty much right away, and it's going to make a steady down. So if you're giving morphine through the IVs, you can see a lot of people have relief right away, but then it leaves your system soon. An opposite, you would take the oral morphine, and it takes a little bit to start working. Okay. This is in your textbook, which I told you to look through. These are all things that affect the drug, and it's one of those things where, yes, it just totally makes sense why these things would affect how drugs are acting in our body. There's a lot of genetics going on right now. So, for example, there's something called Sengens, I think it is. There's different companies, but they draw you do actually a cheek swab. They send it in, and then it tells you how certain antidepressants and drugs for anxiety, psychiatric drugs, are metabolized in your body. So it is kind of helpful when you're trying to figure out what medication works best for your patient when you've tried different ones and it's not working. So they get that, and you can kind of look and say, all right, well, maybe genetically some people don't make a folate enzyme. It's called MTHR gene. So If you are lacking that, then you should take folic acid because that will help the drug absorb and metabolize easier. So that's just one example of genetics of what we're doing with that. Remember, drug-drug interactions that can occur anytime you're taking 2 or more drugs at any time. And as well as foods. Let's not forget food. So if someone has hypothyroidism and they're taking levothyroxine, there's certain foods that they have to watch and maybe limit or moderate. So we think also of warfarin, which is a blood thinner. Warfarin's the generic, Coumadin's the brand name, and these are, remember, those thin your blood. So there's many food interactions because what clots your blood? Vitamin K. So what's in vitamin K? What foods have vitamin K in it? Those are green leafy vegetables, for example. So we used to tell people to avoid green leafy vegetables, but now we're like, no, you can have them, but just don't increase the amount. Just keep it the same way. So if you have a salad a day, keep eating the salad a day, but don't go up to 2 or 3 salads a day because then your blood's going to clot, and you're not going to get your Coumadin level the way it is, or the way it should be. Drugs may alter the results of lab testing also. Alright, so 2 patients are getting some injections of penicillin. One's a male, 35, weighing 165, and the other's a female, 18 years old, weighing 125. So you know that you will see the effects of the drug first in the male patient. Why? A, women have fewer fat cells than men. Unfortunately not. B, men have more vascular muscles than women. C, women have a smaller circulatory system than men. Or D, drugs are generally tested on healthy males. So, ta-da, the answer is B. So men do have more vascular muscles than women. So the effects of the drug are going to be seen sooner in men than they are in women when giving an IM injection. So how do we know? We want them to make sure that they have the optimal therapeutic effect, which is why many times we need to adjust the medications. That's why I have patients follow up with me earlier than later. Because many times, maybe the first dose of the glipizide or glimepiride I gave to the patient for their blood sugars did not bring the blood sugar down like it should, so I will increase the dose. Everybody's different, and so some may do well on a 2.5 milligrams of glimepiride, while some I have to put up to 5 milligrams of glimepiride, for example. This is very common also with antidepressants. Some do great on 50 milligrams of sertraline for their anxiety. But people with depression, many times we have to go up to 200 milligrams. So what I'm trying to say is what works for one may not work for as well for the other. Sometimes we have to switch medication. So that's why history taking and seeing how the drugs are affecting them after they take it are so important. All right, and that's it. I hope this helps.